All right. All right.
So that's adios.
Oh, we're on? Okay.
You're on.
Hi, Valerie Ray. Greetings from DermPath on Demand, Cockerell Dermatopathology. This is part 2 of our lecture from last time. And we're going to skip right down to case number 10. All righty, here we are. And we're going to get started. Our first case is very interesting. Right away, we can tell this is an H&E stain. There's something different about it. This is a PAS stain, and you see this compact keratin. And right away, are you thinking, well, am I in the stratum corneum of a palmar plantar surface, or is this nail? And when you see this degree of compact keratin and this degree of thickness, you need to think about the nail, although at times it can be confusing, believe it or not. We don't see any nail bed here, but we can't help but notice this gigantic, huge fungus ball. I mean, this is just unbelievable, this huge fungus ball. I mean, you really can't miss it. I don't know how anybody could miss this. I mean, you see these slender hyphae, innumerable hyphae, too many to count. Almost looks like pickup sticks. And if you go on higher power, there is some branching. You see septate, it's septated. And you also see tiny spores, yeast. Let's look at another area. There was a better area, actually. There was a better clump that I want to find that really had a ton of spores, because we want to find an area where we can find those spores. Here we go. This is it. It's right here. You can see that in here there are clusters and clusters of spores, and the spores appear to be attached, and they appear to be spherical, and there is branching. So right away we want to think about a dermatophyte. The hyphae are true hyphae. We don't see budding from the buds. We're not seeing any germ tubes. I mean, this is, and to have these microconidia attached. And when you see microconidia, you want to take a quick look around for any macroconidia. And I searched pretty hard. I don't know if any of you all found any, but I did not find any macroconidia. So clinically, this is what we saw. Some white toenails demonstrating onycholysis, subungual hyperkeratosis. It appears to be affecting all of the toenails here, except maybe this one here. The differential diagnosis of this onychomycosis, it was trichophyton meningrophytes. Other clinical differential includes trauma, psoriasis, chronic paronychia, which can be caused by things like Candida. The histologic are yeast forms and non-dermatophyte molds. Contamination, that would be a lot of contamination for that to grow, and it was also invading into the plate. So I don't think you would think about contamination here of a non-pathogenic microorganism. So that would be somewhat unusual. Clinical features, it's a most frequent cause of nail abnormalities. It can cause discoloration and thickening of the nail and subungual hyperkeratosis and onycholysis. And it can be caused by the following organisms. Dermatophytes are most common. Trichophytum rubrum is 60 to 70%, and Trichophytum meningrophytes is second to that for dermatophytes. The yeast, with Candida albicans, you can see it on the fingernails, and Candida parasilysis, you can see that in the toenails. The non-dermatophyte molds like Scytolidium, Aspergillus, Fusarium, Acremonium, and Onychola canadensis. Those are the typical non-dermatophyte molds that you would see. With Scytolidium, that's more of a superficial black look clinically. Diagnostic tools that we can use as the KOH prep, and we can culture it, followed by the histologic exam. Obviously with histology and PAS, you'll get a faster turnaround on the nail sample, and we can use the PAS technique, which is what we saw in the prior slide. So if they're negative, then we can do the PAS if your culture is negative, or your direct exam. Typically the culture will take a while to grow out, so a lot of derms are switching to just doing some nail clippings and sending it for PAS. Oops, not putting that quickly. Hold on. I don't know why it's so slow. Okay, the dermatophytes, T. rubrum, that would be the top portion of the slide. You'll see more clavate to piriform, club-shaped to teardrop-shaped, solitary sessile alongside septated hyphae, the birds on the wire. So you can see they're on both sides. You'll see the birds on the wire. And then the macroconidia will have 4 to 10 cells. In this case, there were 7 cells. T. meningrophytes, you'll see microconidia that are spherical, and that was what we had in our slide. They were more spherical. Sometimes it can be difficult on histology, and you don't have a good macroconidia that's cigar-shaped and between 3 to 8 cells. And then you can sometimes see these spiral hyphae, which typically that's more on the culture than you would see in the histology. The yeast, we can have Candida glabrata and Paracelsus. The top would be the more of the glabrata, and with yeast, you'll see budding and then germ tube formation and then the pseudohyphae. So they're not true hyphae. So you really want to look for the budding, and it's very narrow-based budding, and you want to look for pseudohyphae. With Paracelsus, you'll see more elliptical yeast forms. And down here, we actually have Candida on a slide where you'll see many, many yeast forms. The yeast are a bit bigger than Pityrosporum, and you'll also see these hyphal structures. So, but they're pseudohyphae. You have to remember that and look very closely at them because the septae look pinched. They look more pinched. And then the yeast here are not attached in the tissue. They're not attached to the unless you actually see a germ tube forming out of one of these buds, which sometimes it's hard to find, and sometimes you have to say that you favor Candida over dermatophyte. It can be difficult at times. Anyway, we'll move on to the next case. Oh, one more comment on the prior. When we say onychomycosis on our report, we're including the yeast, the fungi, the molds, and we're not differentiating. When we say Tinea unguium on the path report, we are saying that we favor it's a dermatophyte. So typically when we send our nails, we'll say onychomycosis because we don't get that degree of that many hyphae. We don't have such a beautiful case. We may just have a few scattered hyphae invading the nail plate. So we just say onychomycosis and go from there. So if you want more information, you might have to culture it to speciate it. That's pretty much all I wanted to say on the onychomycosis. The next case that I want to go over with you all is case 11. I don't know if you all had a chance to look at this, but on low power, you see this polypoid, you see these shade that's sectioned, and then you see this polypoid structures that's exophytic. And you also note that the epidermis is missing on the top, and that it looks like there's ulceration here. So the first thing you notice is you see these layers of fibrin and inflammatory cells and red blood cells. And then down below it, you see this capillary proliferation. So right away, you're thinking, well, could this be an ulcer? Could this be a pyogenic granuloma? Hopefully, you don't stop on the low power and you look around on your other slices and you look to see that there's another population of cells here. These cells are clear cytoplasm, and they have very much hyperchromatic nuclei. And you may argue, well, the NC ratios aren't very high here, Dr. Ray. How do I know this is malignant? But you really have to look on high power and see that there's variation in size and shape of the nuclei. They're very hyperchromatic. Their cellular membranes are angulated and irregularly shaped. And if you look around, you can find these cells in mitosis. There are mitotic figures in some. I did find a couple. It's hard to find, when we're on the spot here, but I'll keep looking. The most important feature of this process is that you notice there's interspersed capillaries in between these clear cells. That's really, really, really important. And if you miss that, you could go down a miry path and say, oh, could this be a xanthoma? is this clear cells in a pyogenic granuloma? And then you're doomed, because you're not thinking about the possibility that maybe that this could be, well, it's malignant because these cells are so hyperchromatic and there's mitosis. So first you have to decide, is it benign or malignant? And we have these clear cells, and we have this network of vessels. These cells in here, those are dead center. If you don't see my arrow, I'm not sure if you can see my arrow. These are a network of arborizing vessels, and you see extravasated red blood cells here. So if you wanted to, you could stain it with CD34 and prove that these are actually endothelial cells and not inflammatory cells. Also, too, if you look on low power, you'll see large ectatic capillaries, which helps you decide, yep, there's a vascular stroma here, which is extremely important. If you miss this very arborizing vascular stroma and these packets of cells, this acinar look of the cells. Now, you don't see true gland formation here, and you definitely don't see ducts. So, and it's one big lobule. If you go on low power and back off it again, you're not seeing multilobulation, and you're seeing these vessels here. And then I wondered, is this ulceration of this tumor, or is this part of the tumor itself? And I believe this is part of the tumor itself. It is an ulcerated surface, but yet there are some clear cells intermixed in here with the inflammation. But thank goodness we have the other area here that's this more of a sheet of these clear cells. So some of you are thinking about, well, maybe this is a metastasis, and you're definitely on the right track. Others may be going down the path, well, how do I know this isn't sebaceous carcinoma? And I thought about this. Well, sebaceous carcinoma doesn't have this vascular network. You're not going to see this arborizing pattern and these dilated, so many vessels. Now, sebaceous carcinoma will have a few vessels, but it's not going to have this extravasated red blood cells. There's just so many of them. There's so much hemorrhage here, and there's so many vessels. It's actually part of the tumor. So sebaceous carcinoma, you'll see more basaloid areas, especially with this degree, this degree of invasion and this degree of the tumor involvement of the tissue. Usually with sebaceous carcinoma, you'll see more basaloid areas, and then with sebaceous differentiation. So that's how, and you can put some stains on this. I mean, the PAS will be negative with the sebaceous carcinoma. It'll be positive here. It's diastase labile. So, and you could do a stain for that stain, but that would be positive with sebaceous. But again, with sebaceous, you will have a, there's different stains we can do for sebaceous, like the CAM512, and the PAS is negative. The CEA is negative, but it's also negative in this tumor. So if you really felt like, well, I really think this is sebaceous carcinoma, I don't care, there are no basaloid cells in it, you could stain it. But I don't think you would go down that path very long. So we do need to think about a MET. Well, could this be a MET from the lung? No, because when an adenocarcinoma metastasizes from the lung, it's usually more poorly differentiated. The NC ratios are usually much higher, and you will actually see gland formation, and you won't see this arborizing vascular network typically. Also, you could do a TTF, and you could say, well, it's not lung. So could this be a balloon cell nevus? No, because these cells are too angry and too hyperchromatic and too ugly. So it's not a balloon cell nevus. So if you get on a test and you're like, oh my gosh, and you see that as a choice, just get on high power and decide to yourself, is this benign or malignant? Because this doesn't look like a xanthoma, and this doesn't look like xanthelasma. No way, because these aren't histiocytes, and they're not foamy histiocytes. These are big, angry, look at that, that nucleus is huge. And if you can't figure out if the nucleus is huge, well, look, find a red blood cell and see how much bigger that cell is than a red. It's huge next to a red, this nucleus rather than a red. So even though the NC ratio isn't terribly high because there's lots of cytoplasm, you have too big. And I know a lot of you don't want to do cytology, but sometimes you have to, you have no choice. Unless you want to look at this at low power and say, hey, well, clear cells, that could be a renal cell met. So hopefully you'll get there. On the clinical, we have this pulsatile, rapidly growing, solitary bluish red lesion, but it's in the axilla. So I'm wondering, is that in a node or is that really in the skin? Typically, these occur in the head and neck, this metastatic renal cell. And that's what it is. It's a metastatic renal cell. Some of you already guessed it. I've shown this before when I was here back in December. The differential clinically is a metastatic carcinoma from other organs. Vascular tumors, okay, well, think about capices. Capices, well, you're going to see spindled cells. When it's that nodular, you'll see spindled cells, and you could always do an HHV8. And a primary carcinoma of the skin, well, clinically, yes, you might think it might be a primary carcinoma of the skin, maybe a dermal SCC, I don't know. But it did look kind of bluish. It looked kind of vascular clinically. Histologically, I wouldn't confuse this with a xanthoma because the cells look malignant. Xanthelasma, I wouldn't think these were foamy histiocytes. Sebaceous carcinoma, we talked about that. You'd see more basaloid cells. And if you have to, do the PAS. I mean, if you really, the PAS should be, you know, negative with sebaceous carcinoma and positive with this renal cell. The balloon cell nevus, no. You could do an S100 and a SOX10 and prove they're not nevus cells, and that could help you out if you were lost on that. And during a test, well, I would look for a junctional component. I'd look for something in the junction that was nevoid, because if it's a nevus, it could be compound. So I would look for some cells there, and I didn't see any. Clinical features. So we have this rapidly growing bluish red, sometimes pulsating lesion, usually presenting at the late stage of primary disease. I had one of these last week. I called the client. I said, hello, does this patient have a history of anything in the kidney? And they said, yes, he had a mass in the kidney 5 years ago. And he also had a mass in his lung. So I immediately did the TTF just to cover my bases and make sure it's not coming from the lung. And the TTF was negative. So I definitely said consistent with renal cell. It wasn't this case, it was another slide. Histologic features, you'll get groups of atypical cells with clear cytoplasm arranged in a nested or acinar pattern. The acinar pattern is sort of berry-like. They look like little berries. I guess a blackberry, but they're clear. Interspersed with this intricate arborizing vessels. The EMA will be positive, and please make the correction that the CEA will be negative, and the CD10 will be positive, where eccrine acrosporoma, which is also in the differential, but it's benign and exa lesion, that will be negative. And then you can get the renal cell carcinoma monoclonal antibody. You can use that, which is awesome if your lab has that. Also add to your list the PAX2 and the PAX8. The PAX8 is positive 90% of the time. So I definitely would put a PAX2 and a PAX8 on it. Those would be the stains I would do. Also, some people do vimentin and they see co-expression with vimentin and cytokeratin. The EMA is positive, the CEA is negative, and the CD10 is positive. So that can all lead you to say that, hey, this is the renal cell met. So if you need it, do the stains. It's no problem. They definitely will test you on the stains. So do make that correction that usually the CEA is negative. You can all verify that if you want and look it up. I definitely did in multiple different sources. The next slide is case 12. It was a punch. And I think this punch is very interesting because they sectioned it incorrectly because they actually cut it. They should have cut it vertically and they cut it horizontally. I guess maybe they thought it was on the scalp, but because you'll see here, this is the bottom of the punch cut in two pieces, the panniculus and the lower dermis. Here we're getting down into the panniculus. There's definitely a panniculitis here because you can see inflammation involving the fat. It's very much lobular in this area. Also, too, you notice there are some glands in here that are surrounded by inflammation. I don't know if you can appreciate the lumen here. I don't know if you can see my arrow, so I'll put it in the middle. I believe those are some eccrine glands surrounded by inflammation. Over here, there's some more eccrine glands. I don't know if you can see my arrow again, but I'll put it in the center. So I think you can appreciate those are probably eccrine. I did look around for some apocrine glands just to try to figure out where this is coming from, what site in the body. I like to try to figure that out. Don't confuse this with thick skin. It can't be because you have follicles. And also there's psoriasiform hyperplasia here, somewhat pseudoepitheliomatous, and there's hyperkeratosis. Also, you have the cystic cavity here, and then you have these follicles, 2 of them. So you couldn't just say ruptured cyst because there's 2 of them. You know, could this be a carbuncle? Or could this be, it can't be a furuncle because there's more than one. And then in here you see some possible apocrine glands, but it's difficult to see. The cytoplasm is so much reactive change due to the inflammation. And then over here, I see a bunch of giant cells, multinucleated foreign body type giant cells. They're reacting to something, probably the keratin, coming out of these cystic follicles that very much have thickened walls. And then here's portions of follicles here. I mean, don't call this a keratoacanthoma. Oh, brother, that would be a big mistake. I would, if you worried about that, then I would definitely look at the overlying epidermis and see that there's absolutely no atypia. This isn't psoriasis, that the suprapapillary plates aren't thinned. So you have some rubbing atop this lesion. You have some inflammation in the dermis, a lot of inflammation. It's suppurative in areas, and I'll prove that to you. So whenever I see suppuration, I always think infection, but I don't see any bacterial clusters. This looks very sterile, this process. I see giant cells, but would I stain it for fungus? No, because I have a cause. I probably wouldn't stain it for fungus. I'd look quickly for fungus. You can see it on H&E. I would look inside the giant cells to see if they're engulfing any fungal organisms. But, you know, I have a reason for those giant cells being here, and that's the keratin coming out of these follicles. So we have a suppurative and granulomatous inflammation surrounding these cystic follicles with an overlying rubbing and a paniculitis. So what is this? Well, let's look at the clinical. We have a site that it's in the axillary area. Come in. Hello, come in. Oh, they're not knocking anymore. This axillary area, you'll see some tender nodules. Some of them look like they're draining sinuses, and some areas here that are whitish, that may be scarring. This almost looks polypoid here. That's really bizarre. So, and then here is obviously the groin area. You're seeing a very similar picture. This looks like it's a chronic stage more than an acute stage. Clinically, you know, the final diagnosis is a hidradenitis suppurativa. We definitely used some of that clinical information because we realized it was the biopsy was taken in the axillary area, the armpit. So early clinically, you could think that possibly is it a furuncle if you just see one lesion and a carbuncle. If there's multiple boils and lymphadenitis, sure, you're under the armpit, you're seeing these inflamed, a feeling of there's an inflamed nodule. You think about, you know, cat scratch disease, sure. Typically that occurs in the neck, but you can see it in the armpit nodes. Ruptured inclusion cyst is definitely in the differential, an early lesion, and a painful lymphadenopathy and LGV, you know, chlamydia, typically trachomatis, you can see painful lymphadenopathy, but it wouldn't be in the axilla, it'd be in the groin typically. So you'd have to think about your location there. And the late stage LGV, donovanosis, granuloma inguinale, aka Klebsiella, scrophaloderma, the patient have a history of TB and it would be above some lymph nodes. Actinomyces, you would see filamentous bacteria, sulfur granules, and then the late stage sinus tracts and fistulas associated with inflammatory bowel disease. That's a possibility. Sure, in the perianal region, in the groin, it would have to be in the perineum, possibly. But in that prior photo, we didn't have pictures in that area. Case 12, this is still our hidradenitis. So in clinical features, we have a chronic suppurative, often cicatricial disease of apocrine gland-bearing skin. The initial lesion is very tender, that you could have an abscess that may resolve or drain. The same lesion may appear repeatedly in the same location. Open comedones, unique double comedones may be present. Eventually, the sinus tracts may form. I think we had some sinus tracts in the clinical photo. The pus drains from the openings. You see fibrosis, contractures, keloids can occur. It often involves the axilla, the anogenital region, and rarely the scalp. Histologic features, early there's a keratin inclusion of a hair follicle, there's ductal tubular dilatation, inflammatory changes are limited to the follicular apparatus, and then in the late, the apparatus can be destroyed, the pilosebaceous apparatus. there's fibrosis, and then you'll see some pseudoepitheliomatous hyperplasia. So that biopsy was going into late stage. There was some fibrosis in the lower dermis, so there was some fibrosis there, but not in the upper dermis. But it was between early and late stage on that biopsy. Hidradenitis, if you culture it, well, unless it's opened externally, maybe you could find something in there, but typically they're negative. We did see the foreign body reaction to the keratin, so we'll say there's a foreign body reaction and it's to keratin, which I don't like that term, foreign body reaction. I like granulomatous, but we use it all the time. And then it's part of the occlusion triad. So we can definitely move on to the next case. I think you guys pretty much got that pretty easily, especially with the clinical. You definitely need some clinical correlation, a little bit there. It's not bad to have it. If you don't see those beautiful apocrine glands, and you can tell they're apocrine glands. This is the next case. It's case 13, lucky 13. Not to diverge, but 13 is a lucky number for me. So hopefully this will be a nice, easy case. This is obviously a shave. We have multiple sections. I kind of like this section to look at because it really shows the features well. And I really like, first of all, this process is widespread. It's going from side to side. And we notice this cleft, this gigantic cleft in the intraepidermal location, more in the stratum spinosum, and it seems to be above the basal layer. This doesn't look like re-epithelialization. It looks like a true intraepidermal suprabasilar clefting or vesicle. And then if you look, you'll see these villi. And then some may argue, oh, wow, I think I see acantholysis. You're seeing separation of the keratinocytes. I really want you to study this because the next case that we'll be looking at, we can really discuss this whole term acantholysis. But here you're seeing a little bit of white in between the cells, and you're seeing separation. The bridges are, intercellular bridges are gone, and the cells are separating. Take a quick look at it and just say, hey, I don't see any multinucleation or ground glass inclusions or margination of the chromatin or ballooning degeneration. So it's not herpes. So at least get that out of your head. But herpes usually isn't this widespread. You'll see foci of acantholysis, and it can go down the follicle herpes. But the other thing in the differential is Haley, okay? And this is going down the follicle with these villi, and you're not seeing full thickness acantholysis into the granular layer, which you'd see more at the dilapidated brick. This is more of the tombstone and the villi, which is the buzzwords for what? Pemphigus Bulgaris. And it's not foliaceous because it's not subcorneal. So I think we have the diagnosis even without the direct immunofluorescence. But quickly take one fast look. Look for EOs, look for newts, look for interface changes, because we want to rule out paraneoplastic pemphigus, which will show more interface or EM-like or lichen planus-like look. And we don't see interface. There's no ballooning degeneration. There's no sawtooth. There's no necrotic keratinocytes, dyskeratosis, or a dyskeratotic keratinocyte. So we're not seeing a lichenoid interface process. So right away, I'm not thinking about paraneoplastic pemphigus. Haley, let's get back to that one. Well, direct immunofluorescence, that's why we have it. I mean, that's why we use it. I wouldn't think about Haley because of the follicular involvement. And then you see the roof of this blister is just breaking up. So that explains the clinical appearance, which is the next slide. The clinical appearance here, we're seeing this flaccid, easily ruptured vesicle or bullae on normal appearing skin. And then you have ruptured vesicles leading to erosions. And then you have subsequent crust. We're not seeing the oral area, which I would love to have a picture of the oral area, but we don't have one of those. But definitely check their mouth. Pemphigus vulgaris. The clinical differential is paraneoplastic pemphigus. Histologically, we'll see more of a lichenoid interface dermatitis, and we didn't see that on this slide. Drug-induced pemphigus, yes, that you can't tell the difference. You really can't. If the patient's on Cockerell or a penicillin. So that's why I have a note in my Pemphigus vulgaris that says, you know, think about a drug-induced pemphigus. You need to rule it out unless, you know, obviously, you know, you want to definitely check for that. And the DIF will be the same. You know, you can see, not as often, but you can see the IgG in a fishnet or lace-like pattern, intercellular immunofluorescence with IgG. Paraneoplastic pemphigus, you're going to see something at the junction, maybe C3, IgG, IgM. So you can use direct immunofluorescence to rule out paraneoplastic. But, you know, check with the patient, you know, do you have a hematologic malignancy, CLL, B-cell lymphoma, Hodgkin's lymphoma, IgM, paraproteinemia, all of those, you know, you just ask them, is there anything else going on with you? Many patients have CLL and they don't know it. Pemphigus foliaceus, again, that's more erosions clinically, but it's a subcorneal, and that's why the roof doesn't stay intact like that. Oh, I did want to talk about where to biopsy it with a direct immunofluorescence, perilesional, put it in Michelle's or fresh, but typically Michelle's because it has to be transported. And then for your H&E, you can get the lesion, but definitely don't let that roof fall off, and try to get a little bit of interface so the roof stays on, because we need the roof. We have a little bit of the basal cells, but it's nice to have the roof because it's so much more of the epidermis. Histologically, this solitary acantholytic keratosis, that typically when people send me that, they don't know it's solitary acantholytic keratosis. They think it might be a SEB or a basal, believe it or not. And then I look at it and there's a single lesion, and it definitely fits for solitary acantholytic keratosis. We have a code focal acantholytic disc keratosis, and then you want to rule out Grover's, Darier's. Warty disc keratoma, you're going to see cup-shaped, and you're going to see an invagination. Usually it's only one, and it's a cup-shaped invagination where you'll see villi and you'll see acantholysis. It's a solitary lesion. Darier's, negative direct immunofluorescence, and you want history. The age, adolescent, you want to look at their nails clinically and their palms and plantar area to look for pitting. And Grover's, again, Grover's, you're going to have a negative direct immunofluorescence, and you'll see foci of acantholysis, not widespread. And you can see some EOs in Grover's. Haley, again, it usually doesn't go down the follicle, but again, look for location for Haley. Typically on a test, they'll give you a clue of the site. Herpes virus infection, we talked about that. You're going to see those beautiful multinucleation. Hopefully, sometimes we don't, but you'll look in those follicle very, very hard, and you'll see margination of the chromatin, something to clue you in that this is herpes. I don't think we have a stain for that. Herpes virus would be nice. At this lab, I don't think we have a stain. But it can be tricky. Sometimes we just have to suggest it's herpes. Is this possibly herpes? Shingles rather, herpes infection, usually shingles on the skin. But we suggest it, so please understand why we don't have the beautiful features on every case. Clinical features, round or oval vesicles, bullae with serous content, flaccid, easily ruptured, arising on normal skin. It's more easily ruptured than bullous pemphigoid because that's subepidermal. So compared to what? Bullous pemphigoid, not compared to foliaceous, which you just see like more erosions on that. Usually starts in the oral mucosa. Lesions may be localized for months, after which generalized bullae occur. No pruritus, but burning and pain in eroded bullae occur. It's more common in Jewish folks and Mediterranean descent. Circulating anti-desmoglein 3-in-1 antibodies, which induce acantholysis. And the direct immunofluorescence technique, we can also use indirect immunofluorescence and take the patient's serum. I don't think we do that here anymore at this lab, but we used to, but I'll check on that. Acantholytic epidermis is the histologic feature with subepidermal split, the so-called tombstone and villi, and it does involve the hair follicles. And then the intercellular IgG and often C3, don't forget about C3, can be positive in the fishnet or lacy pattern. And then the indirect immunofluorescence, the circulating IgG that reacts with like monkey esophagus or something. You know, we actually buy the substrate and then we put the serum on it, and then we can look at that under the immunofluorescence scope. So next case is case 14. I hope I'm not belaboring these too much, but we had only 5 cases today to finish up this lecture. Let me put this right side up. This is a great case. I mean, this is just beautiful. Usually you don't get a biopsy this beautiful of this entity. Again, we're seeing some vesicles. We're seeing this may be re-epithelialized, or it could just be that it's intraepidermal. And, you know, I don't like to use the term acantholysis here. I like to use the term ballooning more, because I don't see separation between the cells. I see the cytoplasm more ballooning up. And when you get this a process like this, you always want to look on the side for spongiosis. And we see where we can see prominent intercellular bridges here. You see more of a spongiotic appearance. And there's some papillary edema in this area. The papillary dermis is almost gone. And look at the epidermis here. It almost looks necrotic because it's getting pale and washed out looking. And it's not that our stain is bad or something. Because if you look over here at the epidermis, compare the epidermis here, which is more basophilic, to this eosinophilic, sort of pale, washed out, and the nuclei are getting pycnotic. So this is necrotic, and this is hyperkeratosis and some parakeratosis. And I don't believe it possibly was on the dorsum of the hand, but I believe this is actually hyperkeratosis and not just thick skin, although it might be on the hand. So, but this is more than you would normally see. I'm looking for a follicle to see the site, what site they took this from. They don't always correlate with the clinical photos. The clinical photos are sometimes canned, so it doesn't necessarily correlate with this case. So I don't want to, no, I don't see any follicles. So maybe this was more, but you do see confluent necrosis here. I'm looking for eos and neutrophils now. Now that I see this confluent necrosis, intraepidermal vesicles, and I see spongiotic vesicles, I'm starting to think about, well, is this allergic contact derm? Is this an irritant contact derm? Is it a phototoxic dermatitis? And I see some newts up here. There's a little collection of them. So let's look at the clinical. We've exhausted that slide. Multiple erythematous burning eroded areas localized in the hand in a patient with a history of exposure to harsh cleaning solutions. Wow, if you have that history and then you have that biopsy, I think you can call this an irritant contact dermatitis. I mean, that history is so nice and beautiful. So it was an irritant contact dermatitis. The differential both clinically and histologically is allergic contact derm. There can be a clouded picture because you can have an agent that's allergic as well as irritant. So you can see eos and you can see neutrophils. So you can't always use that. You really need clinical correlation. Dyshidrosis, I've never seen that degree of intraepidermal vesicles with dyshidrotic eczematous dermatitis. An id reaction can look like an acute spongiotic, can look like a subacute spongiotic, you can look like a chronic spongiotic, but you know, id reaction. And a phytophotodermatitis, again, will look, you know, very similar to a spongiotic process, but you'll have to have the history there too, that there's been some exposure. Next slide. Clinical features is a history of exposure to an irritant, more common on the hands. There's erythematous macules, papules, plaques. In severe cases, is erosions, vesicles, and bullae can be seen. Chronic cases, you can see desquamation or flat out confluent necrosis, as we saw there, fissuring and scaling. Histologic features, the changes vary with the nature of the irritant, including its mode of action and its concentration. There's a thick zone of parakeratosis, and we did see that there. There's ballooning of the keratinocytes. So that's why for me, I see ballooning there. I don't see acantholysis. When I think of acantholysis, I think of separation between the cells, like you see in Haley, Darius, Grovers, and Pemphigus. Here, I think of more of ballooning degeneration of the keratinocytes. But no inclusions, so it's not a viral effect. It's due to this irritant. The neutrophils are present and they're usually greater than the eos. And if it's more eos, you think allergic contact, and the spongiosis is seen in the adjacent epidermis. So do look around for the spongiosis nearby. And the dermal papillary edema, and there's some perivascular lymphocytic infiltrate may be seen. So we can move on to the next case. Last case, case 15. Oh, wow, this was on the end of the slide. Nice. You have a very, very thin shades. Very thin shades. This was actually a beautiful example, and I think that's why it was chosen and it was put in the DermPath presenter, because it's just such a beautiful case. Maybe if I had this slide only, I could go down a miry path and start saying, wow, could this be MIS? But then when I go looking around, because you really have to look at every piece, I see some upward migration of these cells. And oh, could it be Mycosis fungoides? Well, the cells don't look cerebriform. They look pale and the nucleus is round. That's why they say the nucleus is round, because it's not cerebriform. And I think that's a mitotic figure, holy mackerel. That's a malignant cell. I mean, I don't know if you can see the cell I'm looking at, I'm putting in the middle. That's a malignant cell, okay? I mean, it's hyperchromatic, it's angulated, very, very dark, high NC ratio. I mean, that's a very, and then the upward migration, it's even going into stratum corneum. But you notice the stratum corneum looks otherwise basket weave. So someone may think, well, could this be squamous cell carcinoma in situ with just some pretty ugly cells? Well, you would see some change in the stratum corneum. I mean, something, some parakeratosis. I don't see that. So I'm leaning away from Bowen's or squamous cell carcinoma in situ. Do I see melanin in these cells? Look for melanin. Now there can be some melanin that just sort of gets in there. So don't see, like right there, wait a minute, is that melanin? But you'd see more melanin than that if this was a melanoma. Can a melanoma have a prominent nucleolus like that? Cell in the middle, yes. So melanoma is my differential here with, I think I've thrown Bowen's out on this. Just doesn't look like Bowen's to me because these cells look paler and lighter than the nearby, the cytoplasm looks paler and lighter than the nearby keratinocyte. That's why it's not Bowen's. And the keratin layer. And do I see invasion? And do I see full thickness? No, they're percolating, they're upwardly migrating, and that's the classic definition of Paget's. So is it Paget's disease? Haha. So we better think about Paget's. Quickly look at the sheet, see where we're located. Are we on the breast? Are we in the genital region? That's what we do. That's what we do. We look at that sheet and see the location. If we weren't given a location, you know, we could start staining it galore. There's another clue on this slide that is huge, and that's why it was chosen, why somebody could call this outright without a single stain. And I'm going to show it to you right now. And if you see this on a test, run and jump on this answer. You see that? That is a lumen, and that is a gland. Therefore, what is this? This is adenocarcinoma in situ. And that's the definition of Paget's disease. It's an adenocarcinoma in situ. It's in the epidermis. There's no invasion here. Oh, we found out, oh, this is in the genital region, vulvar region. So it's extramammary Paget's disease without a single stain because of these lumen. Oh, and there's also, I saw a vacuole in one of these cells. You may think, oh, come on, don't give me the cyto stuff again. But you've got to look at your cyto because there's intracytoplasmic vacuoles. That isn't one. I don't think that's one up there, but I found one for sure, for positive. I found an intracytoplasmic vacuole. And see, there's a little vacuolization of the cytoplasm, but if you see intracytoplasmic vacuoles, you think about an adenocarcinoma. So, and that's what Paget's is, it's an adenocarcinoma. So, is it primary or secondary? All right, but let's go to the clinical. Let's go to the fun stuff that you all love. And the clinical, well, I'm going to do the best I can to describe these areas. In the vulvar area here, we have this pinkish velvety looking area on the labia majora minora, and you have these white islands here. And that is that's something you need to look for. It may even be going inside the vagina. Here you have this irregular plaque, thickened plaque that's red, very red, almost beefy red with these satellite areas. It's almost eroded up here. That looks like cancer to me. The middle looks like cancer to me for sure. Is it Bowen's? Is it Paget's? Yes, yes. Here it looks, you have the islands, white islands down here at the base of the scrotum, and then you have this ulcerated, oozing area that is very suspicious for Paget's. Anyway, it was extramammary Paget's. So the clinical differential candidiasis, I don't know on the middle one if I would think about Candida. because it was so thickened. And we can obviously do a fungal stain so easily, but it's harder for you all because, you know, you don't have 40 XIs. The eczematous dermatitis, yes, but the middle one, again, I wouldn't think it was that. I don't know, maybe. Lichen sclerosis looks different, completely different. Lichen planus, squamous cell carcinoma in situ, I definitely think is in the clinical differential. Histologically, mammary Paget's disease, if you're only at the slide, you don't have the site, you think about extramammary Paget's and mammary Paget's. Toker cells, oh gosh, these Toker cells. If it's on the nipple and you see Paget's-like cells and they're pale, but they don't look malignant, you think of these Toker cells. But some people are finding that they may be a precursor to Paget's cells, Paget's disease cells. So I don't like these Toker cells. If I see them, I'm going to still be very suspicious, and I'm going to look for mitoses. I'm going to look for nuclear changes. I would be very nervous to say, oh, they're Toker cells on the nipple. I'd be very nervous to do that. Melanoma, S100, SOX10 can immediately help you with that. Squamous cell carcinoma in situ, what stains can we do? A 5 and a 6. The main stains that we want to look at is the CEA. The CEA is going to be positive with Paget's. It's going to be negative with squamous cell carcinoma in situ or Bowen's disease. CEA will be negative, obviously, in melanoma. The S100 is negative with the Paget's, but it's positive with melanoma. So you can do a bunch of stains. The P63 for Bowen's you can do, and the CK5 and 6 you can do for Bowen's. The gross cystic disease fluid protein, that's a good one. I think cystic disease fluid protein, that's definitely one you might want to try for Paget's, and that could really, really help you out if your CEA is equivocal or your CK7 isn't positive for some reason, you're still suspicious and everything else is negative. You might want to do the gross cystic disease fluid protein. So you have a choice. You have a very, very big choice. Your PS with diastase will be positive. Your muci carmine will be positive. And you know, you might want to, if this is a male, you might want to put a PSA, a prostate specific antigen on those cells to see right away if it's positive. You could say, hey, it's coming from the prostate. Yippee. Oh, that would be great. And if you want to try to prove it's colonic, you might be able to do, you might do a 7 minus a 20 positive. You know, that typically occurs. You know, if it's secondary extramammary Paget's, it might be coming from the perianal colonic area. It could be coming from a bladder adenocarcinoma, which is rare, but you can see urothelial adenocarcinoma. It can happen. And then the prostate, it can come from the prostate. Primary Paget's, you know, which is coming from the underlying glands, and I'm not going to get into debate on which glands, the apocrine or the eccrine. I just won't go there. But the 7's positive and 20's negative, so that might help you to say primary. But typically, we need the clinical to tell primary from secondary. So we just say extramammary Paget's, and you all have to go searching in the patient's body for where it's coming from. And a lot of family practice docs don't understand that, because I've had them and I give them the answer and they don't know they're supposed to look. They don't know because they're not dermatologists. And then they sometimes, you know, you just have to tell them you need to look internally. So, and not to say anything better about family practice doctors. Oops. But I didn't mean to, but you know, sometimes it's so rare. Let's face it, it's rare. It's rare for everybody. But anyway, so that's our last case. Is there anything else I can say on case 15? Let's just see. Oh, there's a little bit more clinical. Slowly spreading plaque in the genital area, atypical cells with the abundant pale cytoplasm. That paleness is important in the roundness of the nucleus. And there's that rare glandular formation. If you see that glandular formation, you should be able to get it on the test and say Paget's. And then they'll give you a site and you can say extramammary. It's on the breast, it's mammary. And think about the an adenocarcinoma, the underlying breast. So, or in situ in the lactiferous ducts, you know, you have to look for breast cancer. All right, y'all, I'm gonna let you go so you can get back to your jobs. And oh, important, one more thing on extramammary Paget's. Don't forget about the endocervix. It can be coming from the cervix. I forgot about that one. That's huge. And I don't know how I forgot the cervix, especially with that vulvar lesion. So you have to get, I guess, OB-GYN involved and look in their cervix and look at their past path labs and see if their pap smears were abnormal. All right, guys, I'm going to let you go. Have a great day. And if there are any questions, email me at vray@dermpath.com, vray@dermpath.com. Bye.